have an interesting chapter an important chapter, that is hydrocele clinical examination. So I'm sure at least 10% of you, 20% of you will be getting an hydrocele case as a short case in the exam. So these are some cases which will be having no excuse if you make any mistake. So you should be thorough with the complete contents of hydrocele. So let us now discuss about the hydrocele. So before going to hydrocele, again, let me go back to the anatomy of testis. So have a clear idea about the anatomy of testis. So anatomy, please remember, this is the tunica vaginalis layer. Two layers of tunica vaginalis. One is visceral layer, another is parietal layer. And inside you can have all the seminiferous tubules, and all the gonadal cells, all are seen inside the testis substance. So these are the testicular substance. They will be now going on joining in the head of epididymis. This is known as head of epididymis. So now this is what I'm now drawing is called as tunica albuginea. So tunica albuginea is covering all the 6 cord cells and also the seminiferous tubules. All are covered by, this is tunica albuginea. Tunica albuginea. And this is parietal layer. This is visceral layer of tunica vaginalis. So sperm produced inside the testis is now going to enter into the epididymis. And this is a classical head of epididymis. This is a body of epididymis. And this is a tail of epididymis. You can see this is a tail of epididymis. This is epididymis. And from epididymis, you can see the vas coming up like this. This is a vas deferens. So this is vas deferens. So the pathway of sperm may be asked as a question for you. So the sperm produced from the testis is entering into the epididymis. Okay, entering into the epididymis, and it is traveling along the body of epididymis to the tail. Then it goes along the vas, and through the vas it goes on. In the retroperitoneum, it is going in the retroperitoneum. It forms a boundary of triangle of Doom. When we are discussing hernia, you know that. And finally, sperm travels for long distance. It becomes tired and fatigued. So it needs energy. So this is given by a seminal vesicles. This is known as seminal vesicle. Like a grape, it will be appearing on dissection during cancer rectum. Seminal vesicle will secrete. What is it? What does it secrete? It secretes fructose. Okay, it secretes fructose. So fructose secreted from the seminal vesicle gives energy for the cells, for the sperms, and which will further move on into the ejaculatory duct. So after joining into the seminal vesicle, it is called as ejaculatory duct, which enters into the substance of prostate. And this is a prostate, and it opens in the prostatic urethra. This is prostatic urethra. So don't get confused in this anatomy. This is a very basic anatomy of production of sperm and how does it go. So sperm is produced from the testis, from the seminiferous tubules, and it is going into the head of epididymis, travels in the body and travels in the tail and the vas deferens, and finally enters the prostate and enters into the prostatic urethra. Then it comes into the penis. So on ejaculation, it is going to come out of the penis. So this is a classical anatomy. So now we are going to discuss a chapter on hydrocele. Hydrocele, please don't forget, it's a classical topic. It is of two types: primary hydrocele and secondary hydrocele. Okay, secondary hydrocele. So primary hydrocele is due to defective absorption of the fluid. So there is a defect in the absorption of fluid is called as primary hydrocele. There is some problem that fluid is not getting absorbed. So they are getting collected between the two layers of tunica vaginalis. So hydrocele is collection of fluid between the two layers of tunica vaginalis like this. So this is typical defective absorption of fluid. Whereas secondary hydrocele is one which there is excess production of fluid. So excess production of fluid, but it is usually absorbed. Since absorption is present there, it will not become so much big size. So the size will be small size only. Secondary hydroceles are small size, whereas primary hydroceles will become big size, massive size. They can reach very massive size because of the defective absorption of fluid. So whatever it is, the color of fluid in both the cases is amber color fluid. So amber color means it's like a golden yellow color fluid, and the fluid contains cholesterol crystals. So cholesterol crystals are present in the fluid, and very important, it contains one component, fibrinogen. So fibrinogen is a very important component in the hydrocele sac. For example, this is a hydrocele sac containing clear hydrocele like this, clear fluid like golden yellow color fluid is present like this. If this is a clear-cut fluid containing cholesterol crystals and fibrinogen, if I put a drop of blood into this, what will happen? If I put a drop of blood into this fluid, what will happen? Immediately the fibrinogen will act and the entire fluid will become a hematocele. So fibrinogen is the one which makes the hydrocele become a hematocele. Please remember, it forms clot. The hydrocele fluid gets clotted and look like a hematocele even if a drop of blood mixes. So blood mixed with the hydrocele fluid becomes a hematocele because of fibrinogen. So this is a basic point. So please don't forget, defective absorption of fluid is primary hydrocele. Excess production of fluid is secondary hydrocele. Before going to the examination history taking, I want you to be thorough with this basics. Then only you will understand the questions we are going to ask now. So secondary hydrocele is due to many causes. As you know very well, secondary hydrocele are due to many causes. Very important causes in India includes filariasis, trauma, arthritis, and last class we discussed about tumors. So tumors. So like that, many causes are there. Filariasis, trauma, arthritis, tumors, etc. Now coming to the primary hydrocele. Primary hydrocele is nothing but collection of excess fluid in the hydrocele sac. Now let me tell you, there are many types of hydrocele. So based on the anatomy I'm going to draw, this is processus vaginalis, which can be seen continuing into the scrotum like this. So this is a testicular substance. This is testis. And you can see now in this picture, you can see there is a collection of fluid from the abdominal cavity is coming into this and collects in the testis, in the tunica vaginalis lies. What is this type of hydrocele? The picture I have drawn here is having a communication with the abdominal cavity. It is due to patent processus vaginalis. So patent processus vaginalis, there is a connection with the abdominal cavity, and therefore there is fluid getting collected in the scrotal sac. This hydrocele is called as congenital hydrocele. This is called as congenital hydrocele. So in congenital hydrocele, there will be fluid collection in the scrotum, as well as it is slowly collected all along the root. And as the baby is waking up in the morning, if the baby is in the morning wakes up, the swelling is not seen because overnight it has gone into the abdominal cavity. Morning, no swelling. In the evening, the mother notices slowly the swelling enlarged. Swelling is present in the evening. In the gravity, it is like a gravity, it is descending into the scrotum, and the swelling is found in the evening. So now the question is, as the mother tries to push it back, it won't go because it's not a so much big hole, it is a small hole. It's not a big hole, so it will not go on pushing. So not reducible manually. This effect is called as inverted ink bottle effect. Inverted ink bottle effect. It means what? It will fill up by itself for the full day, but it cannot be pushed back inside. This is called as inverted ink bottle effect, and this condition is called as congenital hydrocele. So congenital hydrocele. Please don't forget congenital hydrocele. So you all will be discussing in hernia also. Hernia is also same. Instead of the fluid, if bowel is present inside or omentum is present inside the sac, it is called as congenital hernia. So congenital hernia is a content, bowel or omentum, whereas hydrocele is containing of only fluid. For both of them, the pathology is same. There is a pattern processus vaginalis. So congenital hernia can be pushed inside, can be pushed manually, because the defect is very big. Because the defect in case of hernia means it is big defect. So therefore it will go back. Whereas in a hydrocele, it's a very small pinhole defect. So in a hydrocele, the defect is pinhole defect. So you don't be able to push back. You cannot push back, but it will slowly get collected. So this is first important type of hydrocele. I want you to know, for both the cases of congenital hydrocele as well as congenital hernia, the treatment is going to be the same. That is herniatomy. We have to cut the sac at this level. We have to completely remove the sac and cut it up to that level. Treatment of both the cases is herniatomy. So herniatomy is a treatment for both congenital hydrocele and herniatomy. So don't get confused in this first topic. So congenital hydrocele, congenital hernia, there is a full processus vaginalis, and you can see there is a treatment, simple treatment, herniatomy. Okay, herniatomy. So now you see the next case of hydrocele. In this case, processus vaginalis is closed. It's not open, it is closed. But from deep ring, there is a continuation of the sac. From deep ring, this is superficial ring. From deep ring, it is present up to the scrotum. So this is a testis. So the testis is now having a opening of the processus vaginalis is present, but it is not having connection to the intra-abdominal cavity. So therefore, this presence has a swelling between the inguinal region and scrotum. So this is closed here. At the deep ring level, it is closed. So this hydrocele shown here complains of inguinoscrotal swelling. The patient comes to you with a inguinoscrotal swelling. This disease is called as, what is it? What is it called as? It is called as infantile hydrocele. Infantile hydrocele. So all the points are based on the vaginalis, tunica vaginalis and the processus vaginalis. So here the processus vaginalis is closed at this place and this place. So it's closed at the deep ring level and at both sides. So there is no connection between the intra-abdominal process vaginalis and extra-peritoneal process vaginalis. It is closed here, so it cannot be reduced. So not reducible. It is not reducible like congenital hydrocele. So this is infantile hydrocele. Please don't forget, this is infantile hydrocele. Don't forget infantile hydrocele. So the next hydrocele. Let me show you the various types of hydroceles are there. The first, next important hydrocele is deep ring, superficial ring. You can see this is a spermatic cord. As the spermatic cord is coming, testis is looking normal, but there is a process vaginalis in the inguinal region, which is getting the fluid collected inside this alone. What is it called as? It is called as encysted hydrocele of cord. Encysted hydrocele of cord. So encysted hydrocele of cord, the patient comes to you with a pure inguinal swelling. He comes to you with the inguinal swelling. He can easily move the swelling. You can easily mobile swelling. But what happens? When I pull the testis down, the movement decreases. So this test, when I pull the testis down, I cannot move the swelling. That is called as traction test positive. So traction test is positive. That is what we call it as encysted hydrocele of the cord. Encysted hydrocele of the cord. Traction test is positive. So this is deep ring, this is superficial ring, this is a spermatic cord coming, and now you are seeing the vas epididymis and the classical hydrocele I'm drawing now. This is a classical hydrocele we are going to discuss now. This is a testis, normal testis, and there is a fluid collection between the two layers of tunica and tunica vaginalis. Two layers, there is a collection of fluid, and it is limited to the scrotum. It is limited to the scrotum. So this is called as primary vaginal. It is called as vaginal because it is having vaginalis layer. So vaginal hydrocele. So it is one which is confined to the scrotum. Confined to scrotum. So confined to the scrotum, therefore you can see they are classically confined to the scrotum, called as primary vaginal hydrocele. On palpation, this is the guy who is going to have the 3 clinical features. Don't forget the 3 clinical examination findings. The 3 clinical findings. This is a finding which is going to tell this is hydrocele. So number 1 finding is get above the swelling positive. I can get above the swelling with the 2 fingers. If I palpate the root of the scrotum, get above swelling is positive. Get above swelling positive means I could palpate only the vas and the cord structures. No sac is palpated and I could feel no sac structure. Get above swelling positive is hydrocele. So get above swelling positive. And since the fluid is a content, fluctuation is positive. So fluctuation, I hope you know what is fluctuation. Fluctuation should be done for swellings which are in cystic consistency. Any swelling with a cystic consistency or with the fluid, we should do fluctuation. So fluctuation means if this is a swelling, if I press on one side, other side, 2 fingers might expand. And if I press here, other fingers should expand. So this is a typical fluctuation. Fluctuation is positive. Cystic consistency, it is present means fluctuation should be done for hydrocele. Usually it is done in any cystic swelling in both the direction. In all cases, it should be done in this direction and also in both directions. But in hydrocele, only one direction it is enough. So in hydrocele, it is done only in vertical direction, it is enough. No need to do in horizontal direction. The only place where we do only vertical direction fluctuation is hydrocele. So otherwise, bilateral direction I should do. Both upside down, side to side, both side I should do fluctuation. Hydrocele, only one side direction is enough. So that is a second important point. And third point is transillumination is positive. So transillumination is positive because of the clear fluid inside. So if this is the scrotum, I should throw the light at one angle and I should examine with the illuminoscope at another angle. At what angle this should be? So the light should be thrown and examination should be done at 90 degrees. So don't examine. For example, this is a swelling. I should throw the light from here and I should examine from back side. I should not go and examine from this side. So because testis will hinder the shadow of the light and therefore you won't see. So 90 degrees, you should examine the patient in 90-degree angle. So don't forget, the light is going to be thrown at 90 degrees. This is a torch light. I am going to throw the light and this is the illuminoscope I am going to see. So this is going to be the transillumination test positive. So these are the 3 important tests you must do. So examiner will be expecting you to tell the answer for these 3 questions. And when you tell transillumination positive, immediately examiner will be asking what are the places where transillumination is negative. Transillumination negative in hydrocele. I'm asking in hydrocele cases. What are the places if you have transillumination negative means first important thing is improper technique. You should do it in a dark room in a 90 degree to each other. Okay, don't do it in a bright room. First point. So improper technique, it will be negative. Thick sac, the hydrocele sac is thick sac, or the scrotal skin is thick scrotal skin. See, I'm not telling anything else. I'm telling hydrocele, the fluid inside is clear fluid. In spite of clear fluid, improper technique, thick sac, thick scrotal skin and all, you will not be able to do transillumination positive. And if transillumination is negative, there are other causes, other pathologies, other scrotal pathologies should be ruled out. What are they? So they are includes hydrocele complications like pyocele. Infected hydrocele is pyocele, hematocele. Hematocele, sometimes it is due to clot. I told you it is due to clot. The scrotal pathologies like pyocele, scrotal, hematocele are the scrotal complications. And please don't forget secondary hydroceles. Secondary hydrocele, we may not get a clear amber color fluid many times. So secondary hydroceles may be due to filariasis, due to architis. So those fluid may not be clear. Fluid may not be clear. Therefore, there you can be having a transillumination negative. And number 3, calcified sac. In a hydrocele, calcified sac also will not be seen on transillumination. So transillumination negative. What are the causes? Improper technique, thick sac, thick scrotal skin. So these places you will not see a clear-cut hydrocele at all. This is very important point. So please don't forget this question. So now let us go for clinical examination of hydrocele. So what are the things you should ask? What are the things to be done? All those things we are going to discuss now. Yes. Now, first question. So please see the anatomy of hydrocele. This is what I was drawing for you. So swelling is present. 50 years male, Mr. Kumar presented with the swelling in the left side scrotum for the past 6 months, not associated with pain. Only 70 students are attending. We have 750 students enrolled for the clinic for the course. I don't know why most of them are not attending. You should be very serious with this class because these are clinical classes which you will never get anywhere. So this type of number of points, whatever I'm telling, are from various institutes, various faculties. Most of them are collected from various places. So you should be thorough with this. I will be clearing your doubts at the end because I have no another device is not with me. So try to attend the session live. Unless you attend the session live, you cannot get the doubts clarified. I'll clear your doubts. Don't worry. So hydrocele will have the following clinical features. It will usually come to you with a painless enlargement of scrotum. That is a clinical feature and not associated with pain. Most of the time, you don't have any pain. So gradual onset and slow growing for the past 6 months. So you should ask about features which can cause secondary hydrocele. Now, elaboration history, you should ask about recent history of fever with a chills and rigor. So epididymoarthritis, secondary cause of epididymoarthritis can cause hydrocele. So any pain in the testis can be due to pyocele or any other problems. So sudden increase of size should suspect a malignancy or any trauma. So all those things we have to ask in detail. So what are the things you should ask in detail? And at this point of time, it is very important. You should know it is not hernia. Because in the history taking, we cannot know whether it is a hydrocele or hernia. So you should ask whether the swelling gets reduced on lying down. So only swelling which gets reduced on lying down overnight is congenital hydrocele. Otherwise, hydrocele will not get reduced on lying down. One of the important clinical history and clinical examination we are going to see now. So the moment you see inspection, what all things you are noting here? Yes, can you tell me what all things you are noting here in the history? So you should tell the moment you see the examination of the scrotum, you should tell the penis is buried or penis is pushed to one side because of a huge swelling on the left side scrotum. So left side scrotum, there is a swelling with the loss of rugosity of the skin. Penis is buried or penis is pushed to opposite side. Everything you should tell in a clinical examination. So examine the patient in standing position. Skin over the scrotum is stretched and normal rugosity is lost. Subcutaneous veins will be prominent. In case of hydrocele, we can see a constriction around the swelling in most cases due to tight tunica albuginea at that level. Sometimes it will be seen, not always. Sometimes there will be a small constriction thing will be seen in the hydrocele. Look for impulse on coughing. And one important test we do in inspection, it is not done by palpation. We ask the patient himself to roll over the swelling over his abdomen. If it is a hydrocele, they can roll over it. See, such a massive hydrocele with a buried penis. Left side hydrocele only. It's a left side hydrocele with a buried penis. Right side minimal hydrocele. That is rollover test positive. So please don't forget. So what all things should be seen in what all things should be seen in inspection? I'm writing you again. Don't forget the features to be seen on inspection. So inspection of the hydrocele. Inspection of the hydrocele. Number one, look for skin rugosity. Okay, rugosity of the skin over scrotum. It will be stretched. It will be absent. Any veins or scars present. Previously, sometimes surgery would have been done. Any veins or scar is present. Look for any veins or scar and look for penis. Penis is buried inside the enlarged swelling or deviated to the opposite side or pushed to the opposite side. You have to see that. And number four, you should ask the patient to cough. Cough impulse is absent. On cough, I could not see any enlargement of the swelling. That you should mention. Very important because we want always to rule out hernia. and don't ask and ask the patient himself to do roll over the abdomen. Roll over test is done for bigger hydroceles. Bigger hydroceles, not for small hydroceles. Small hydroceles, sometimes they cannot roll it over, but very massive hydrocele, if you ask them to roll over, since it's a hydrocele, the deep ring level, it is there is no continuation, so it will usually roll over. So roll over test is positive. Then coming to palpation. In palpation, be soft and smooth. Don't go and examine roughly. So during palpation, look for any warmth and tenderness. So warmth and tenderness. Touch with the back of your fingers and touch it. So if the patient is telling tenderness, you should not go and examine so seriously. You should tell the examiner that the patient is having tenderness, so I cannot do a deeper palpation. But if it is not tender, you can go for the 3 tests, as I already told you. Fluctuation test, positive. Transillumination test, positive. Then get above the swelling means get above swelling at the root of scrotum. Get above swelling at root of scrotum, you should examine. You should not feel anything else except the vas and the cord structures. So get above the swelling is positive. So now you should also look for cough impulse. Again, look for cough impulse, because always we are confused. There should be no hernia. We want to rule out there is no hernia. Ask the patient to cough out. So the important 3 tests are fluctuation, transillumination, get above swelling. This is a 3 test that is going to give you a definite diagnosis of hydrocele. So please don't forget this test. So cough impulse is just an accessory. We have to always rule out there is no cough impulse. And now the most important and the very important thing in palpation, which you should never miss to tell in the exam. This examiner will be listening, whether you are going to tell it or not. What is it? On a palpation, look, tell whether testis is palpated separately or not. So testis is palpated separately, yes or no, you should tell. It is palpated separately in secondary hydroceles. It is not palpated in primary vaginal hydrocele. Okay, so please don't forget this point. So there will be secondary hydrocele and primary vaginal hydrocele. You should not forget. Secondary hydrocele, testis is palpated separately. In primary hydrocele, it is not palpated separately. Don't forget to tell this point. And also don't forget to tell about any para-aortic nodes or inguinal nodes examination. Para-aortic nodes are palpated in the abdomen. I hope you remember this, to rule out testicular tumors. And inguinal nodes, just for completion's sake, we have to tell. Because inguinal nodes, we have to tell, because mostly inguinal nodes are not involved in any testicular pathologies. Just we have to tell inguinal nodes and para-aortic nodes are not palpable, and left supraclavicular fossa free. So all these are routinely done, routinely told in the exam. So for other examinations, okay, this is very basic point. You should not forget. And if you see, this is a picture showing you the rollover test. Rollover test. So mention the size of the swelling, etc. You have to mention. So palpating the swelling, you should tell it is 8 centimeter vertical diameter, 4 centimeter horizontal, globular or vertical shape, smooth surface, cystic consistency. Therefore, I'm doing a fluctuation. Fluctuation is positive, and I have to go for the get above swelling. If the get above the swelling, I should only palpate for the cord structures, and I should look for a transformation in a direction perpendicular. Illuminoscope should be passed perpendicularly. And tell me, the moment you tell this question, they will ask you what are all the other swellings which are transillumination positive. So when you tell transillumination positive, tell me what are the other swellings which are brilliantly transilluminate positive will be asked. Yes, tell me what are all other swellings which are brilliantly transilluminant. So transilluminant swelling come from above below. Transillumination positive. Number 1, ranula. So come from above below. So from the above below, therefore you won't forget. In the mouth, ranula. Under surface of tongue, ranula. Number 2, in the neck, cystic hygroma. cystic hygroma. Number 3, so from the spine level, you can get meningocele or meningomyelocele. So meningocele, myelocele or spinal cord defects. So spina bifida defects, spina bifida, they come under neural tube defects. So therefore there is protrusion of the structures, neural tube defects. So ranula, cystic hygroma, meningocele, meningomyelocele, and don't forget fifth one, epididymal cyst. It is also found in scrotum, epididymal cyst. And number 6, hydrocele. So epididymal cyst is one which is going to have an interesting transillumination called as Chinese lantern-like transillumination. Chinese lantern-like transillumination is present in epididymal cyst. Please don't forget it. Okay, it is having a Chinese lantern type of transillumination. So therefore, they will definitely ask you hydrocele, epididymal cyst, ranula, cystic hygroma, meningocele are the swellings which are going to have transillumination positive. So don't forget to palpate this test separately. Test is palpable or not. Sometimes you can test for testicular sensation, but usually it is not advised. The patient is having testis separately palpated, you just press it and see for any sickening sensation. Look for heaviness of the scrotum because I want to rule out testicular tumor. Never miss the opposite testis, penis, abdominal nodes, inguinal nodes. As I told you, never miss them. And finally, the diagnosis is a case of primary vaginal hydrocele. And they will ask you the differential diagnosis. The differential diagnosis are all types of architis. So don't get too much confused in the differential diagnosis. Differential diagnosis, we are going to tell about the differential diagnosis. You are going to tell about, apart from the hydrocele swelling, which are all swellings confined to the scrotum. Number 1, architis, all type of architis. Whether it is an epididymis, bacterial, or syphilis or TB. So number 1, architis. Number 2, testicular tumors. That is what I was telling you. You will be brought into some other topic in examination. Tumors. Number 3, tumors, hematocele, or you can tell about hematocele, pyocele, chylocele. So these things you should be able to tell. So please don't forget architis, tumors, hematocele, pyocele, chylocele. So here you should not go and tell all the causes of all the differential diagnosis. You should not tell. So you should tell differential diagnosis of a swelling confined to scrotum. So I'm seeing many times the students go and tell unwantedly the differential diagnosis are inguinoscrotal hernia, varicocele testis. They're all not needed. So don't tell them. Only you should tell differential diagnosis of scrotal swellings. That's all. Okay. So now what are the Viva points usually they ask you? I told you about the primary and secondary vaginal hydrocele. So now you should know everything about primary and secondary vaginal hydrocele. Don't forget it. That's most important. So differential diagnosis, don't go and tell. Don't tell what? Don't tell varicocele testis. So don't tell hernia and all for scrotal differential diagnosis. All these are differential diagnosis of scrotal swelling. That's all. Okay. Don't tell anything else. So now you have confirmed it is a hydrocele. Now tell me what are the investigations you will do. See, any surgery patient, please remember, surgery, if I am going to do, the following investigation you can tell for all cases. What are the following investigations? Complete blood count. You write in the case sheet, complete blood count, blood sugar. Always I want to rule out whether the patient is having any diabetes. So RFT, renal function test, means urea creatinine. So renal function test. For major cases, I will also do liver function test. So liver function test, bleeding time, clotting time. And for major cases, I will also do prothrombin time, INR, for major surgeries, major cases. Okay, for major cases, we can even do prothrombin time, INR, and also you can tell blood grouping typing. So please don't forget, this is a basic blood investigation we do for any surgery case. Any surgery case, major case we are going to do, we do this basically. And then we will go for the other important investigations. Like for anesthesia purpose, we will advise X-ray chest, ECG, all the leads. And mandatory, since a patient is going to be going into the OT and we are going to be touching the patient, for our safety, we will do 3 important tests: HIV-1-2, HBs antigen, anti-HCV. This is for our benefit. For our benefit, we should do this. So whatever mentioned here is a basic investigation for all surgery cases. Basics for any surgery. Any surgery. The only thing you should not forget is LFT, prothrombin time INR will be done for major surgeries. Not for smaller surgeries, they don't usually do those things. So X-ray chest, ECG, all those things are done for surgery. And for specifically hereafter, you should know specific investigations for all cases. And I'll tell you, we have to do ultrasound of the scrotum. Ultrasound of the scrotum is very important investigation to be done for this case. In ultrasound scrotum, I should ask the radiologist to tell about testis, whether it is atrophied or testis, any mass present, everything should be given by radiologist. So in testis, if they suspect any mass, then they should even advise MRI of the scrotum is also nothing wrong. When they suspect any mass, they should go for MRI of the scrotum. That is also nothing wrong. So ultrasound scrotum to look for atrophied testis or any mass or any dilated pampiniform plexus of veins, dilated veins, that also can be seen. So these are the very important things that you should not forget. On examining of the scrotum, don't forget to look for testis and dilated veins or any atrophied mass, atrophy or mass. All those things will be looked in the ultrasound scrotum. So usually no other investigation needed, only ultrasound scrotum is enough for hydrocele. And if it is a clear-cut hydrocele, the treatment of choice is what? Treatment of choice for a small hydrocele with a thin sac. What is the treatment? Small hydrocele with a thin sac. And what is the treatment of moderate hydrocele? Moderate hydrocele. Moderate or large hydrocele with a normal sac. Hydrocele with a thick sac. Thick sac, moderate hydrocele. What should I do? Moderate or large hydrocele? So this is very important because if it is a thin, small hydrocele, what is the procedure done? So the procedure done is very simple. Large plication of sac. See, large plication of sac. See what I'm doing here. This is the hydrocele sac. What I will do? I will just open it. I open it and I will plicate the sac like this. I will be plicating them so that they will not be, I will open like this and I will plicate like this. So this is plication of sac. So plication. So that what happens now? Hereafter, the fluid which is secreted from the tunica layer will be absorbed by the scrotal lymphatics. So scrotal lymphatics will absorb the excess fluid. So the problem is what? Difficulty in absorption of fluid. Now the scrotal lymphatics will take over the fluid hereafter. So that is large plication of sac. Then Jabalize eversion of sac. So Jabalize eversion of sac so that there will be no fluid collection again. So what we do? This is a tunica vaginalis, means we open it, we evert it like this. So that is Jabalize eversion of sac. So again the same concept. The excess fluid which is this is a testis means, and this is a everted sac. The excess fluid which is secreted will go to the scrotum and the scrotal lymphatics will absorb them. So please don't forget this. And thick sac, we have to do excision of the sac. Excision of the sac is must if it is a very thick sac. Excision of the sac plus overrun the sac. Cut sac should be sutured. Otherwise, what will happen? It will bleed and it will go for hematocele. Therefore, always excision of sac done means we will keep a drain is must. If I am keeping an excision of sac, drain is must. Because if I excise the sac, hematocele chances are very common. Hematoma collection is common. Hematoma is common. Therefore, keep a drain if you are doing an excision of sac. So 3 types of surgeries: large plication, Jabalize eversion, and for a thick sac, I should excise the sac and overrun the sac. Continuously, I should run over the sac so that there should be no bleeding from the sac wall. Please remember, this is very basic point. You should not forget. So the surgical treatment options are these two, Jabalois, lots. Thick sac, we have to do excision of the sac. So two more scrotal swellings which are not so important for exam. They may only ask you as viva. Epididymal cyst and spermatocele. They are also scrotal swellings only. Spermatocele. Please understand spermatocele and what is epididymal cyst. Epididymal cyst is nothing but, I already told you, this is a classical congenital remnant of Wolffian or Mullerian duct. Epididymal cyst is what? Congenital remnant of Mullerian duct or Wolffian duct. So those remnants which are present in the epididymis or in the testis, they form collection of fluid like this. They form collection of fluid like this, and it is clear fluid. Please remember, it is a clear fluid. Therefore, there is transillumination like a Chinese lantern transillumination. Chinese lantern like transillumination is present in these cases. So the main point is it is a clear fluid. And don't forget it is congenital and it will be bilateral also. Bilateral also. Whereas what is spermatocele? Spermatocele is an acquired condition in which there is a collection of sperm in the head of epididymis like this, forming a hard swelling, firm to hard swelling like this behind the testis. Behind the testis, there is a swelling like this formed, and it contains acquired condition. It is an acquired condition with the sperm, which contains sperm. Sperm is present inside. Therefore, it is having a color called as barley rice color, barley rice fluid color. It is barley rice fluid color and it is firm consistency. So when I palpate it, it is palpable like a 3 testicular appearance in the scrotum. 3 testicle appearance in scrotum is seen in spermatocele. See, actually spermatocele is not transillumination because it is having a barley white color fluid. But Bailey and Love gives wrongly as it is transillumination may be positive. So transillumination may be positive is given in Bailey and Love, but actually it is wrong. It is usually not transilluminant. So the point is you have to operate for both of them. But in case of this congenital case of epididymal cyst, since it is bilateral, when we operate both sides, they can go for infertility can happen. Infertility can happen. You should tell them very clearly, infertility can happen because we are going to remove both sides. Whereas that complication will not happen in spermatozoa because it is usually unilateral only. Okay. Spermatocele and this thing, don't forget. You can see the clear fluid shown here. That is an amber color fluid coming out on opening of the hydrocele sac. Some questions which are usually asked by the examiners to know whether you went to theatre or not. What is the color of hydrocele fluid? Amber color. What is the color of the hydrocele sac? It is bluish color. Okay, what is the color of the sac? It is bluish color. And what suture material will you use when you are everting the sac or when you are plicating the sac? I should use Vicryl, polylactic acid is usually used, or catgut is usually used. These are the pictures showing you the hydroceles I demonstrated. Don't worry, hydrocele of the canal of Nuck is like same like encysted hydrocele of the cord. There is another hydrocele known as hydrocele of the canal of Nuck. So the investigations I told you. So what are the complications of hydrocele? Hydrocele can go for infection, atrophy of the testis, hematocele, or hernia of the hydrocele sac. So two important things I'm always seeing students getting confused. Want to tell about it? So calcification of the sac and rupture of the sac are very rare complications. This hydrocele sac, which is blue in color. So now let me tell you two important things. That is, one is complications of hydrocele and complications of hydrocele surgery. Please understand. See, this is a classical complication. This is a huge hydrocele. Okay, this is a huge hydrocele. Let us assume this is a huge hydrocele. And this is a scrotal skin. See, in the scrotal skin, if the dartus muscle becomes weak, through the darkness muscle, the hydrocele can come out like this and can protrude below the skin layer. Below the skin, it protrudes like this. So skin, and this is darkness muscle which became weak and the hydrocele is coming out. This is called as herniation of hydrocele sac. So don't get confused. I'm going to tell you three things. Herniation of hydrocele sac is this picture. So classical picture I have drawn here showing you the hydrocele sac has come out of the darkness muscle. Herniation of hydrocele sac. Number two, I just did a herniorrhaphy, deep ring, superficial ring. I did a herniorrhaphy operation using a mesh. During the time of operation, I probably closed the superficial ring or a deep ring very tightly. So what happened? So therefore, the scrotal lymphatics are not able to go back. The scrotal fluid, no, they are not able to go back. So they are collecting fluid in the scrotum or even in the tunica layer. So there is a fluid collection happening because I have made a tight herniorrhaphy with tight rings. That is why when we are doing the deep ring level, when we are keeping a mesh, we have to keep a small gap so that the lymphatics will drain. So this results in a hydrocele known as post herniorrhaphy hydrocele. This is called as post herniorrhaphy hydrocele. Post herniorrhaphy பண்ணதுக்கு அப்புறம் வர hydrocele. Post surgery hydrocele. This is post herniorrhaphy hydrocele. The next hydrocele is Gibbon. Please understand, Gibbon is a very famous author who wrote a very famous book of Arise of the Egyptian Emperor. He will be like this. He will be like this. He will have a huge scrotum like this. Huge scrotum like this. So such a big author, there those days the dresses and all will be looking so bad. So he used to go for tapping. So those days they used to do tapping of the hydrocele. So when he went for tapping one time, what happened? They have injured a bowel containing inside like this. It was actually hydrocele for a long period. That time he has developed a hernia also. And these people, when they are doing the tapping, they punctured the bowel and they caused peritonitis. Therefore, Gibbon's hernia is hernia plus hydrocele. It is called as Gibbon's hernia. Actually, it's a hernia. It is containing hydrocele plus hernia. So when tapping, this Gibbon died because of peritonitis. That is why it's called as Gibbon's hernia. So Gibbon's hernia. Please don't forget this point. So the complications of hydrocele surgery, the common complications are hematoma, injury to the testis, injury to the epididymis, wound infection. All these things can happen. And this is a famous personality known as Gibbon's hernia. Yes, let us see any doubts you have. Please tell me the doubts. This is about the hernia with hydrocele chapter. It's a small chapter, but full of MCQs. You should not forget. Okay, you should not forget the MCQs which are asked in the exam. So this is about the hydrocele. Any doubts you have? So let us see your queries. So many of you have chatted in the questions. Let me see one by one. Yes. Okay, I will stop the streaming so that. Yes, very good, Shruti. That's correct. Your answers. The fructose is coming from the seminiferous seminal vesicles. Yes, congenital, there is any sac. So sac, hydrocele, there is no sac. Hydrocele sac கிடையாது. Hernia தான் sac. Hydrocele, it is usually